Hello and welcome to today's webinar, Big Changes for 2020, CMS Blockbuster Announcements. Before we get started, I'd like to review a few brief housekeeping details. Today's session is being recorded, and an online archive of today's event will be available a few days after the session. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the Handouts tab. The antitrust statement prohibits us from discussing competitively sensitive information. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen. We're very fortunate to have with us today Dr. Michael Cantor and Mr. Bruce Greenstein. Dr. Cantor is the Chief Medical Officer for CareCentrix. He is also a geriatrician and attorney with extensive experience in designing and implementing population health and quality improvement programs for health plans and healthcare providers. He trained in internal medicine at Beth Israel Hospital in Boston and did his geriatrics fellowship at Harvard Medical School. Bruce Greenstein is Executive Vice President and Chief Strategy and Innovation Officer for LHC Group. He has spent the last 25 years in healthcare, split between the public sector and private sectors. Today, he runs strategy and innovation at one of the nation's largest post-acute care companies. In 2018, he was the Chief Technology Officer at the U.S. Department of Health and Human Services. In state government, Bruce was the Health Secretary for Bobby Jindal in Louisiana, and before that, he was running Microsoft's Worldwide Health and Human Services Business Division. At this time, I'd like to turn the floor over to our speakers.
Thank you so much, Catherine, and hello, everyone. Welcome to our webinar. Bruce and I are thrilled to be here with you today to talk to you about some really interesting changes happening in CMS policy. And just to give you an idea of the agenda, what you see here on the slide is we're going to start by talking about kind of the big idea. So everyone's on the same page in terms of understanding what's happening at the policy level. Then we'll talk a little bit about what is changing, and then we're going to get into a question and answer discussion with Bruce initially about what the implications are, and think about how you can incorporate these changes into a 2021 Medicare Advantage bid. Then we will conclude our comments and open the floor up for questions. So I hope that as we go along, you can type questions into the area you see on the right side of your screen so that we'll be able to answer them and have dialogue about the things that you have more questions about and want more information about as we go along. So without further ado, let me share with you kind of the big ideas. And really, there are two major changes in Medicare policy that are taking place. And it's not that they're happening overnight, but there's certainly a lot of indication that these two big changes are beginning to happen. The first change is shifting the focus of Medicare away from acute care to chronic care. So when Medicare started in 1965, it really was about hospital payments and making sure that people who were acutely ill could get the care that they needed. Certainly it covered some outpatient care, and a lot of other types of care were added over the years. But what's really clear now is that 80% of the costs in our healthcare system are related to chronic illness. And over time, the numbers of dollars being spent to manage chronic illness are shifting. And Medicare, recognizing that we need to really focus on improving management of patients with chronic illness, is shifting away from just focusing on acute care and really thinking about how do we keep people out of hospital as much as how do we manage them when they're there and pay for those services that are needed. The second big change is really trying to deliver as much care in the home as possible. In other words, bringing the care to the patient instead of bringing the patient to the care. So even outpatient settings now are not necessarily the optimal place. We begin to see, and we'll talk more about this in a slide or two, we're beginning to really see some shifts towards covering care in the home, remote patient monitoring of patients in the home, bringing services like hospital at home. These are the things we'll talk about during the course of this afternoon's webinar, and really get into some discussion about how is CMS approaching this and what are the implications of these shifts to bring care to the home. That's the big idea. More chronic illness focus and also more focus on bringing care to the home. Before we get started going into that, I'd like to talk about kind of 4 major principles that we think are critical for providing better care. And this is something that our organization, OHC and CareCentrix, are completely aligned on. First, we always ask, especially for post-acute care, is it possible for the patient to go home? In other words, is a discharge planner in that hospital unit thinking about home first and asking the question, instead of why should this patient go home, why shouldn't the patient go home? What are the barriers to that patient being discharged home, and how do we remove them so the patient can go home first? Even in the non-post-acute care settings, in primary care and in chronic care, to the extent that we can deliver services in the home, which is where people want to be treated, it's where they are, it's easiest for them, those are the questions that people want to know. How can I get more care in the home? The second principle is really making sure that all care is patient-centered. And by this, I mean not just a jargony term where we're thinking about patients as part of our overall strategy, but really making sure that all of the care is targeted to the specific needs of that patient, whether those needs are clinical or whether they're non-clinical, like housing, transportation, what people now call the social determinants of health. Thinking about what patients need, what their functional status is, who are their caregivers, what community resources are available, allows us to then create a care plan or a strategy for that patient's health care that really meets all of their needs, not just the ones related to diagnosing and treating underlying medical problems. So that patient-centeredness is both holistic in that it covers many different areas related to health, and it's tailored and specific to the needs of each individual patient, because each of us has different medical histories, certainly, but also home and community needs and resources that are available to us. The third principle is collaboration. The old saying is healthcare is a team sport, and that's true not only from the perspective of the clinicians involved in taking care of patients, physicians, nurses, social workers, pharmacists, physical therapists, et cetera, but also thinking about organizational collaboration. So how do organizations like CareCentrix, which manages home health benefits and post-acute care for health plans, how do we approach managing? As I was saying, technology, like telephonic technology, is a tool. It is not a goal. And so the whole plan is, the way that we think about technology is not that we want to have the best possible technology platform, but rather with the best technology tools enable us to more effectively collaborate and communicate to take care of patients, especially those with complex needs that are medical and non-medical, and also to analyze who is the highest risk, to use predictive modeling to understand what's likely to happen to patients and populations over time. And by applying these 4 principles of home first, patient-centered, collaborative care, and tech enabling all of these services, we feel will be best able to deliver the care and meet the needs of our patients, of our neighbors, of ourselves. So let's move on to why the future of care is in the home and what that looks like. Here what we see is that we need to shift from today, which is along the top part of the slide, to tomorrow. So today, for example, care in the home tends to be episodic rather than continuous. So home health services are often low frequency. They're focused on acute needs or perhaps post-acute care. And there's still the idea that we need bricks and mortar. We need to be able to have buildings to provide care. In the future, we're going to have more continuous care, and individual patients and people will be connected. Already some people wear devices like certain watches or other devices that monitor their movements to understand what is their activity level. Right now, that's something that you can choose to do or not to do, but there is no sort of organized way that that's incorporated in most people's health planning or needs. Similarly, it's oftentimes the case that in order to get healthcare, you have to actually go to healthcare. We see more virtual care. We see the ability for patients, and it's already happening, for people to use telehealth and video conferencing to get services on demand and to really be able to interact with the healthcare system when needed, and at the touch of a fingertip to be able to get someone's help right away without having to necessarily go to see that person at a clinic or in a hospital setting. And we think that it's going to be site agnostic. So if I need to be diagnosed for an acute issue, or if I need to be helped managing my chronic illness like high blood pressure, it's going to be site agnostic to the extent what that means is that I won't have to go to a clinic. I won't have to go to a hospital. I'll be able to have video chats with my doctor, or work with the nurse practitioner or the nurse or the pharmacist. Whoever's helping me will be available in real time, and it won't matter where I'm located or where they're located. We'll still be able to collaborate and work together. That's what's coming. Similarly, we see a shift from singular to multidirectional. So right now, a lot of information goes from doctor to patient. In the future, we see lots more of exchange back and forth between patients and a healthcare team. So moving from just one point of care to team-based, accountable groups of clinicians and healthcare managers who are working together to really make it a bidirectional flow of information between the patient and their family and their caregivers and the healthcare providers who are helping them achieve and maintain their health. And finally, we'll move, as I said before, from that kind of one-size-fits-all generic approach to a much more patient-centered, specific, targeted healthcare plan that will enable patients to get what they need in a very specific way, one patient at a time, which will also enable patients to express their goals and to share information about what they want and need so that their needs are met. When you add all this up, what it comes back to is sort of those two big ideas of really focusing on care in the home and moving from an acute focus to chronic care focus. And what you see on this slide is sort of a listing of 6 different areas, examples where CMS, the Centers for Medicare and Medicaid Services that oversee the Medicare and Medicaid programs, these are 6 recent policy initiatives that are definitely shifting care to the home and also are focusing a little bit more on chronic illness. So for example, supplemental benefits means that Medicare Advantage plans can begin to offer non-healthcare related benefits like transportation or nutrition. Home health payment changes, this is an example of where CMS is changing how they pay home health agencies to focus more on medically complex patients, focus a little bit more on patients coming out of the hospital in terms of the payment rates. It's really shifting more towards valuing care for complex patients rather than just patients who need certain types of physical or other therapy to recover from illness. Home dialysis is an initiative where the CMS is trying to move care patients with end-stage renal disease who are on dialysis from dialysis centers to the home. And so ensuring that dialysis providers are encouraged and in some cases strongly encouraged financially and programmatically as a measure of quality to provide more of that dialysis care and kidney care more generally in the home setting. The hospice carve-in, basically this is an opportunity where starting in 2021, Medicare Advantage plans, the managed care plans for Medicare beneficiaries, they will be able to offer hospice as part of their benefits package. In other words, carve it in. Home infusion, this is a new benefit. Congress passed a law last year which allows for patients to get infused medications at home and have it paid for by Medicare starting in 2021. So here another example of shifting care to the home. And a similar example in terms of shifting care to the home is remote patient monitoring. So really allowing patients to be monitored at home for chronic illness. So high blood pressure, high blood sugar that's often accompanies patients with diabetes, et cetera, et cetera. So really these policy changes where CMS will be paying for remote patient monitoring, but we'll see these other benefits as well. All of them are going to impact the way that Medicare beneficiaries can access health services and what will be paid for in terms of health services or even non-health related services. So this is a time now when we ask the audience to do a little bit of work. So in order to figure out what topics Bruce and I are going to cover today, we thought we would ask you to rank what you think is the most important topic of the list you see of the 6 CMS policy changes I just mentioned: supplemental benefits, home health payment changes, home dialysis, the hospice carve-in, home infusion, or remote patient monitoring. So we're just going to take a minute now to allow people to vote for what is the most important topic. So please take advantage of your opportunity to click on one answer. Okay, so now everyone can see the results, and what we see in terms of the top three is that supplemental benefits, as it tied with remote patient monitoring, for 28%, and just behind them at 26% are the home health payment changes. So Bruce, are you ready?
I am ready.
All right, so let's start with supplemental benefits. So let me just very quickly describe, or actually, Bruce, why don't you take us through sort of what's happening with supplemental benefits, and then we can talk about what the implications are for these changes.
Yeah, so what I love about the MA program is it gives CMS an opportunity to essentially try out and give flexibility to the Medicare Advantage plans to go ahead and offer and deliver up benefits before CMS makes a final rule change in the fee-for-service program. And what we're seeing is, and my company as a provider have signed on to provide personal care. We have personal home helper here, so non-clinical people to come to the home. Many MA plans have contracted with us to do it, but we're seeing slow take-up for either individuals asking for it or MA plans to use it. But the idea is make it easier to get home from either the hospital or from a skilled nursing facility and address those, what's often a social barrier or what people don't have as supports at home from their family or community, and instead make home an option rather than staying in an institution. So transportation, a non-emergency transportation, just as a way to either get to medical appointments or even home from hospital or SNF. Food delivery, believe it or not, we hear many times that people end up getting discharged from the hospital to a SNF because in many cases, the patient doesn't have a spouse and doesn't have somebody that would be able to prepare food for them. And that's the major threshold for them to get over in order to be able to live independently and recuperate at home. And so we're seeing MA plans come up with really innovative contract methods to supply food that's clinically appropriate, nutritious, and it has to taste good. I won't name the plan, but I was really impressed after talking with a friend at a plan that we work with, and I asked, where are they getting their food from? And it was Golden Corral. And not really the healthy food option that you'd think of first, but they went in and drew up a contract and were able to get chicken breasts and potatoes and vegetables, something that met the needs for their patients at a good price. So we like what we're seeing, and we think over time MA plans will look at these as a way to reduce the total cost of care rather than just seeing it as an extra cost in their offerings.
Got it. So CMS, just to be clear, when CMS allowed the Medicare Advantage plans to do this, they did not give them any additional resources, right? So when the health plan decides to hire LHC to provide the personal home helper hour or whatever it might be, CMS didn't say, okay, we're going to give you an extra X dollars to cover the cost of that. How much of a barrier do you think that is? You mentioned it's kind of slow uptake. Do you think that's a big barrier, or what do you sense are sort of the challenges in getting these new and innovative approaches disseminated through Medicare Advantage?
Yeah, so there's probably 2 or 3 different ways to look at it. One is it's a new benefit for an MA plan to offer. So even though somebody that might be working in utilization management or care management or discharge planning, the notion of having personal care attendants is intellectually not new, but using it is. And so most plans have capped the number of hours available per year. And as I've talked to a lot of my friends in plans that ask for us to contract with them, you could tell that they're moving slowly and with caution, which is a good thing to do. And what I ask them is, listen, get your network built out, but then come back to me afterwards so that we can look at ways to think about your personal care benefit as a way to manage the total cost of care for your patients. And if you think about it in isolation, it's just cost additive. If you think about it as an overall strategy to peel back, maybe, to lose over your whole population 1 day average length of stay from SNF, or being able to get a patient home from the hospital 1 day earlier because you're going to offer a personal care attendant to be able to stay with the patient and family for the whole rest of the day that they're there and come back early the next morning to help the patient and family out with transition. That's something that I think will take a little bit of time for MA plans to ingest that skill set and use that benefit strategically. But I know it's going to happen because in other cases where we're working with, let's say, health systems that take risk and we partner with them, it's being used effectively in many cases around the country today.
Got it. And when you look at the transportation, healthy food deliveries, personal home helper, there's a whole litany of other potential supplemental benefits, home modifications, respite care, whether that's in-home or people going out to adult day health. If you can think of an idea, you can probably, as long as it's directly related to improving or maintaining the patient's health, you probably could offer it. What do you think is like the top one or top two that plans are putting in place? And if you're thinking about, if you were a health plan, which ones do you think are the most important for them to focus on to reduce readmissions, for example, like you said, reduce length of stay in a skilled nursing facility?
Yeah, so the transportation piece is often used, I think it's used most widely and often used on its own. In fact, we think about it as a way to get a patient to see the primary care doc before a medical issue exacerbates and ends up with a hospital or ED visit. So that overcomes a significant barrier. And, in the Medicaid world, transportation has been covered all along. Bus passes or taxi rides have been given, non-emergent transportation, and it really goes to address, some of those issues that block people from accessing primary care. In this case, MA plans are doing the same thing, using it wisely, and so I think transportation, again, widely used, on the right track. I think what is interesting, and you'll see it shape over time, is that MA plans, in conversations that we've been having, are beginning to put pieces together to turn it into a sort of an antidote to a longer length of stay. So we call a packaging of some of these services a home ahead or home faster program. And if you think about, just reverse engineer from the hospital perspective, what keeps a patient in the hospital longer than they otherwise would like to? And a hospital has, in a DRG way, an incentive to line up benefits to be able to throughput their patients out of the hospital. For an MA plan that's paying per diem, there's an incentive to line up low-cost benefits to be able to help the patient move back home. So if you have the ability to arrange transportation, have, let's say, pharmacy picked up on the way, have meals for the first, say, 5-7 days. I like to do meals for 2 people, encourage either to help the family or to have a friend come over and spend time. And then oftentimes a family or a patient and family advocating for them, with still an amount of fear and anxiety from the medical episode, would try to keep as much of the institutional safety of being in the hospital or a SNF as much as possible. And here the idea is to be able to provide as much of that anxiety reducing and clinically appropriate care in the home at low cost to be able to move patients back to the home where they really want to be, as long as they could overcome that fear and anxiety. So the packaging of benefits, I think we'll start to see over time. I think that if you go on the conference scene, there's so much discussion about social determinants of health. I think about these as social factors that influence this behavior. And I think the more packages that we put together that are easy to order up and easy to consume, we'll start to see better throughput from SNF and hospital to home a lot faster.
I would agree, and I think that your idea, of looking at this as a package or an individual benefit, at CareCentrix, we agree that that's clearly the way to think of it. So think about what a readmission reduction package looks like in terms of transportation to the doctor's office for that follow-up visit, home deliveries of meals, the personal home helper you talked about, even medications, making sure the meds are refilled or refillable. And so designing it around specific clinical needs that address more than just a clinical condition or diagnosis and get into some of the social determinants, I think is probably the way it's going to move in the future. We're still seeing a lot of health plans today, or at least some in the initial year. In 2019, some plans did offer access to supplemental benefits. We anticipate many more will in 2020. Unclear what the scope will be in 2020. I'm waiting until next month when the open enrollment begins and we can see what the benefits packages will actually look like. But I think there will be a little bit more thought about not just offering a specific benefit, like up to 6 rides or 12 rides a month or whatever it might be in terms of transportation, but to think about fall reduction package, readmission reduction package, those things that address those more complex situations where you really need to bring together multiple services to meet the needs of the patients.
That's
so
right.
Let me
and
actually...
over time...
Go ahead.
Go right ahead.
I was going to move on to our next topic, but if you have something else to add to this one, please feel free.
I was just going to highlight, like you said, as we've worked with MA plans, they get very good at the individual attribute. Let's say on fall reduction, a number of plans that we work with have done PERS units, personal emergency response, that have accelerometers in them. And we've done work to identify people that are at risk for falls, and then we go in and do an intervention, which would be a little home modification and some maybe gait training and prepare the patient. But what I see happening is, as those that are doing care management within an MA plan, or if they're working with a partner that is doing the care management on their behalf, putting together these package of benefits allows a care manager to sort of prescribe a package for the condition of the patient, or using your reference to predictive modeling before, where patients that fit into some population health category for risk, you are able to prescribe this package that should be able to keep that risk down or under control and prevent much larger expenditures later on in the benefit year or in years after that. So I really like what I'm seeing here. I hope that MA plan people that are listening just get more curious about it, reach out for help, whether it's internally or to other plans or to people like me and you to get more education on this, because I think the more we do this, the better overall the conditions are for the patient and the lower total expenditure.
Great. I'm going to skip ahead, and actually it's a really nice segue when you mentioned personal emergency response systems, to remote patient monitoring, which was the second most popular topic after supplemental benefits. So there have been some recent changes in terms of payments for remote patient monitoring, or RPM. Do you want to describe kind of what those changes are and what you're seeing, and perhaps what your experience has been so far in using remote patient monitoring devices?
Yeah, so this is from my background in technology. I've been looking for technology in the home to solve so many healthcare problems for at least 20 years. And the problem has really never been technology. It's been around payment systems and where the information goes. And CMS is recognizing some of the problems, at least. And now there are CPT codes that allow for physicians' offices to bill against these codes when they have patients at home with remote patient monitoring. Home health is allowed to put remote patient monitoring in homes, and the billing goes back to primary care physicians. So complete alignment has not been completed. And at the same time that that's happening, while I said technology didn't stand in the way, over the last 20 years, it's gotten a lot better. And so where maybe even as recently as 10 years ago, we were dealing with set-top boxes and wired devices, today the notion of scales, wearables, a hub that is wireless and maybe operates on 2 different cellular networks to be able to roll off of one onto another, whichever is up and has the best bandwidth, and then myriad other devices, that you're able to connect to it. It could be a spirometer, a pulse oximeter, blood pressure cuff, etc. Now, so the question is, all that data has to go somewhere. Someone has to monitor it, and then if values are outside of the acceptable range, somebody has to do something about it. So we've not seen broad, scalable execution of a strategy that does this seamlessly and has the information get back to, let's say, the primary care physician or the health plan very well. We've seen a lot of pockets of activities, some proof of concepts, but we haven't seen this go broad. And I might use the CCM codes, or chronic condition management codes, as an example of another benefit that CMS put out. It's being used somewhat broadly, but I don't know if it's really made a difference in enough of the patients' lives, mainly because there's this segmentation of data. So I'll just suggest something that we're seeing how it's working well. We're in the home all the time, and we partner up with health systems. Many of the health systems who we partner have take risk on from MA plans or have their own MA plans themselves. And so we act as at that first level and monitor patients, watch the data, and then because we are in the home as a post-acute care home health company, when we see values that go out of range, we're telephonically reaching out to the patient right away, and we send nurses as follow-up to that. So we're able to both monitor the patient, but I like to call what we do is remote patient management. It's much more hands-on, and we have a relationship with the primary care physician, and we, in many cases, are financially aligned where we might have some kind of value-based arrangement or shared savings arrangement. So for us, it would make sense to spend a little money by adding an extra visit to keep, for us in the home, in order to keep the patient out of the emergency department, or reducing another hospitalization or rehospitalization. So kind of sum this up here, there are a lot of companies that are recognizing that CMS has made payment available now. Again, I think this is forward thinking and enlightened. Now the market sees this as an opportunity to make money. Now it's up for those that actually pay for things like MA plans to figure out how to get real value out of it, not just to buy a technology game or just new pieces of devices, but instead really work it into a clinical workflow, make sure that there is some reaction to the action of the values that the patient is creating, and that there is alignment in the whole model, so that everyone has a part to play in the taking care of the patient, and they're rewarded the right way to keep the patient healthy, managed, and out of the hospital.
Got it. And from the health plan perspective, I think my own experience, like yours, goes back 20 years almost to the first time we put scales and blood pressure cuffs in the home of patients with heart failure, back when I was working at the VA, and saw good results in terms of being able to manage those patients more closely. Like you said, remote patient management. The challenge has been the financial models haven't aligned, the payment models haven't aligned. So here's a step forward, right? The CMS is recognizing value and saying, okay, we're going to pay for physician activity, for example, in a way that hasn't been possible before. What are you seeing, Bruce? I mean, are people coming to you and saying, we want everybody to be monitored with heart failure or diabetes that meet certain criteria? Are you really growing your population of patients that are monitored at home? You mentioned all the things that should be aligned. I'm just curious, what's happening today? Are plans and providers and the home health agencies like yours really stepping up, or does it sound great, but we haven't seen much movement yet?
Yeah, it falls mainly in the second category. I would say caution and prove it to me first is what we see. We have several thousand patients that are under remote cardiac management. I'm not going to name proprietary, company or devices, but we manage these patients that are for CHF in the home, and we do several thousand patients with PERS. And PERS has become sort of the gateway to remote monitoring. It allows us to keep in touch with the patient. It does monitor exactly what it's supposed to. In the case of emergency, press the button. And we have several thousand button pushes a year, and we've got good data on what's false alarm, testing it out, asking a simple question, or real emergencies. And in work that we've done with some health plans, we've seen that we're recognizing falls that go unreported, but the device tells us that the data that shows up, that looks just like a fall, even though the button wasn't pushed. And so we're able to go ahead and follow up. In some cases, patient is on the floor. In other cases, they got up and they're not feeling well. And then we get a chance to go and check on them. So as plans see the value in each incremental step from PERS today, and it could be the full complement of remote patient monitoring devices in the home with a patch that's monitoring vitals. It could be a wearable that's in the form of a shirt that's monitoring pressure in the lungs, temperature, heart rate, etc. We're just seeing very small steps. And again, I think it's the time for plans to put together their internal strategy and be really disciplined about getting their partners / vendors to work with them under the auspices of has to create value, has to provide a major benefit to the patient, and it has to save money. And once we start to see more examples of that, I think you'll see more and more plans going this route and utilizing it to manage total cost of care.
Got it. So you don't necessarily see these CMS changes as being like the green light, floodgate open. It's more green light, cautious stepping up, people beginning to move in that direction, but it's still going to take a little while. Is that right?
Yeah, that's both what I'm seeing, and that's my medium-term bet. I don't think we'll see the floodgates open up. I do think you'll see vendors that are going to figure out ways to use the codes to create additional revenue. But again, this is what I love about working in the MA community, you got to show value in savings, or else just billing more is not creating value. And so that's the real litmus test to me.
Right. Value is higher quality at lower cost, right?
Yeah, exactly.
So you've got to show the quality and the lower cost. And if you have higher costs, you have to show much higher increases in quality to offset that. So that makes sense.
The last thing I'll say is that probably what will be as much of a challenge going forward in terms of all the challenges within remote patient management is doing it. But the other challenge is the targeting of the right patients. Because if you're going to put, for every 100 patients, you'll expect, say, a reduction in hospitalizations by some number. If you put the wrong patients in, or way too many patients into your pilots, you're not going to get the savings that you need. So targeting and using your own algorithms to select the patients that have high current costs today will give you a much better perspective on what it would be like to save money across a much broader population in the future.
Got it. That makes sense. I'm now going to move to our third and the final topic you and I will discuss before we open it up for questions. We knew we wouldn't get to all 6 topics, but we thought we'd put them out there. The people spoke, and so we move on to our final topic, which is going to be the post-acute and home care payment models. And so, as Bruce, as you more than well know, the patient-driven groupings model, PDGM, is the new method for paying for home health. The PDPM, the patient-driven payment model, is for skilled nursing facilities. Let's just, in the interest of time, let's focus on the patient-driven groupings model, the PDGM. which is changing how home health agencies are going to be paid by traditional Medicare. Tell me what that means to you as a large, really large national home health provider. What are the implications of this? What are the implications for the patients? How do you think it's going to impact the way that Medicare Advantage plans pay for your services, or will it going forward?
Well, it's certainly the most profound change in payment methodology that home health has seen in over a decade. I've been pretty public about how I feel about PDGM in general, and even though what gets picked up in the news is my critical comments, I'd have to say probably 90% of the rule is great. Let me tell you a couple of the things that are in there. One is today there are a number of these groupings. Think about it like a DRG for home health. There's about 100-something groupings today, and under the new rule, it's going to go to over 400. So we'll be more specific about the coding that gets done for the condition of the patient. CMS has also been clever about figuring out what patients home health companies tended to like to treat more, because there's maybe greater revenue on the other side. So therapy patients got a lot of attention, and wound care patients didn't get as much attention. CMS has recognized that and really equalized things to make all patients interesting to providers from the revenue side. So I think that will help engineer the program a lot better. The next big change is going from one 60-day episode where CMS saw some providers finish up their care within 4 weeks or so, and what CMS is saying that we want to buy care over a discrete period of time, so we're going to do 2 30-day groupings. If you finish your care in the first 30 days, you're done, okay? If it's going to take you over 60 days, then we'll pay you for 60 days. So that's another policy change that I agree with. The last piece is just around the payment rate. CMS is using something that it's calling behavioral assumptions. So it's predicting that home health companies will bill higher and more, and under a budget neutral rule, CMS is making a cut of about 8% of the payment rate in order to account for what they expect to be higher billings. Well, the industry doesn't agree with CMS. We think that cut is overstated, and there's comments going on. The rule is out for comment right now. So those pieces are all in action, and it's scheduled to start on January 1st of 2020 once the rule closes. So remains to be seen what the final rule looks like. We'll be waiting as well. Your question, though, is what does that mean for MA plans? So MA plans, not many have subscribed to the traditional methodology for payment. Some do, and it becomes much easier. I could say that the way that MA plans contract for home health typically requires a lot of administrative work, authorization of a certain number of visits, and then when more visits are needed, usually not as much as the request gets granted, and that amount of back office time tends to be a much higher percentage than the Medicare side, which is done as an entire episode, and you get paid one block of money for as many visits as it'll take to get the patient ready for discharge. I think that over time, you'll see MA plans start to look at ways to package up or bundle some of these services instead of having it be just a series of authorization and utilization management. I think that through this PDGM next year, you will see a lot of smaller home health providers that are financially struggling today end up just hanging up the towel and going out of business. I am not pleased with that, because the idea, just as a recovering regulator, I like to see that we have adequate networks around the country, that all Medicare recipients, when they go home, have access to high quality home health. And in this case, I think it puts a lot of that in jeopardy. I think that MA plans will watch what's happening in the market. As they do, we'll be able to provide feedback with, our industry with large MA plans where we make up part of the network across the country. And I think it's an opportunity for MA plans to just kind of go back and think about how to use care in the home. This is to the greater context of our discussion today. How to use care in the home to be able to deliver more benefits, a better user experience for the patient at home, reduce the overall total cost of care, and do it in a way that is integrated with other benefits that the health plan is offering as well. I think this is it's another reminder that the way that we organize and pay for care in the home is changing. It's probably a good time to just examine the way that plans are doing it today.
Got it. So as part of that larger strategy, looking at supplemental benefits, considering remote patient monitoring, thinking through how you pay your home health agencies, it makes sense to have a strategy from the health plan's perspective that drives more care to the home. By choosing for the right patients, as you mentioned, targeting a minute ago, the right technologies, the right services, the right length of time, the right intensity, to make sure that people can go home and stay home for those who've been hospitalized, or even better, that they get the care they need at home and don't have to go to an emergency room and end up staying in the hospital. So it makes sense for an MA plan to kind of review comprehensively, now that there are all these different initiatives, and ones we didn't get to, the home infusion opportunities to deliver home infusions at home rather than in hospitals or in nursing homes, the opportunities to improve the care of patients by offering more hospice and palliative care services in the home, dialysis at home. So it's a really good time for health plans to step back and think about how do we continue to shift care to the home where their members live and want to stay, and how do we take advantage of all these different options to make that happen. Having said that, let's go to questions and answers. This time always seems to go faster than I think. I always think it's going to go. We're going to have plenty of time, and then boom, things have a way of wrapping up very quickly. So just in terms of closing thoughts, you just heard me say this is a great time for Medicare Advantage plans to consider their strategy. They're putting their bids together. What do you want to build into your bid for 2021? Are you ready to think about remote patient monitoring, the supplemental benefits, the thinking through the opportunity for remote patient monitoring and the others that we talked about today? But let's hear the questions that health plans have, or our audience participants have, some health plans, some not, for us. So, Catherine, do you want to begin by asking the first question?
All right. So the first question, where do you think CMS will draw the line with respect to, quote, not primarily health-related, unquote?
Yeah, so I guess what are the limits of defining the supplemental benefit, Bruce? How far do you think they will go beyond just a more traditional home health approach in terms of supporting benefits for patients at home?
So that's a good question. I don't feel strongly that I have the answer, but you can tell just from you draw a line through the trajectory of the recent loosening up of the supplemental benefits. I haven't gone back to look at the law and the rules that these are authorized under in quite some time, but there is a broad recognition that there are these social factors in their home, their family, and the community that distort the overall cost of healthcare that they consume. And so the more flexibility that CMS gives MA plans to be able to do what is non-clinical activities that brings down the overall cost of care, I think that's going to be a direction that CMS continues to go for quite some time.
But you think about Medicaid, and you mentioned Medicaid and long-term support services as a place where people may be able to access benefits for transportation and meals and so on and so forth. Do you see that Medicaid sort of package of long-term support services, or LTSS, as the model that Medicare will eventually shift to, or do you think it goes further and include things like housing?
Yeah, so I've talked about this around the country for years. It feels like in the world of social benefits in general, housing, food, education, they have not seen the increase in funding at the state level or federal level in years and years, but healthcare has. So advocates for patients have looked to healthcare to finance all these other parts of social benefits that haven't been funded very well. I think that if we use Medicaid as the example, it will strike fear in the Medicare regulators' eyes as well as health plans, because when you have a very, very broad entitlement, it tends to get maybe overused where it the expenditures far exceed what the value that you get out of it. I think going in a slow and cautious approach, but using the data and evidence from the Medicaid world will make the Medicare program be able to be built more strongly over time. And listen, I think that Medicaid's not finished innovating and evolving either. The notion for Medicaid to be able to address social factors, and housing, by the way, is one of the most difficult pieces to address. And in some cases, states are doing a great job of providing the right kind of housing to keep people out of institutions and healthier and happier. I think those kind of experiments and innovations will continue to evolve. I think that the whole of all of CMS's programs get better because of that.
Great.
Catherine, next question.
Yes. Which of the supplemental benefits in particular is most impactful? How and when will we know?
What do you think, Bruce?
Well, Dr. Cantor, I'll give that one to you to start with.
So this is the challenge of understanding how to measure the impact of offering supplemental benefits. I see that there are several different benefits from a health plan perspective that these supplemental benefits offer. So first, there's a marketing benefit. So if your plan is in a competitive market with a lot of other health plans that are offering supplemental benefits, in order to gain and even maintain market share, it may be that the health plan has to consider making an investment in supplemental benefits. Supplemental benefits that are available to more people, to Bruce's point a second ago about Medicaid, are the ones that are likely to be valued by the members. And so things like transportation, meals, even money for paying for over-the-counter pharmaceuticals, things that we don't, they're not the exciting or more innovative supplemental benefits, but things that people have tried and have done for a long time. Those are the things that may have the most impact from a marketing perspective. From a true clinical benefit, from thinking about what's going to reduce readmissions, what's going to reduce falls, what's going to reduce admissions in the first place, I think that there are a couple of directions that health plans can go. As we talked about earlier, I think it's really important to think about a target problem to solve and to bring multiple potential benefits to solve that problem. So for readmissions, transportation to the doctor's visit, nutrition at home for 2 weeks, offering home health aid services for a day or two, what Bruce called the Home Ahead program. So really a package of services designed to help the transition of the patient from the hospital or skilled nursing facility to the home, really likely reduce readmissions, which are high-cost events, so probably a place to focus. I would argue that we're a little further away from what you might call sort of chronic illness benefits. So thinking about programs for patients with diabetes or dementia or Parkinson's disease, heart disease, where again, you could offer specific targeted benefits packages. I think it's going to be a harder model to measure in terms of what the impact is of like a heart disease management program, which includes nutrition, access to dietitians, I'm making this up, other things, because there's so many other factors that can affect the patient's, heart disease management, whereas a readmission reduction program or a fall reduction program may deliver results more quickly. It is going to give your actuaries a lot of pause within the health plan because today there are no randomized controlled trial of large-scale benefit design changes with the proper data, with the proper biostatistically significant results. And so little of this has to be on leap of faith and based on, I think, what Bruce said, which is looking at other programs like Medicaid to understand how has the transportation benefit made an impact? How has the nutrition benefit made a difference? There are a lot of small studies in the literature now, for example, about the impact of food, and the whole food is medicine movement is making the case, study by study, that paying for medically tailored, nutritious meals under certain circumstances, like for patients with diabetes or for patients coming out of the hospital, does make a difference. The jury is still out on exactly how to do that and where to do it and for whom. But those are the areas, I would say, transportation, nutrition. But again, thinking about it more holistically than just randomly giving people meals or rides, trying to make it targeted to produce a desired clinical result, which will then in turn lead to reduced costs. Does that make sense, Bruce?
It does. It brings me back to the early 90s when Medicare MCOs were paying for drugs before Medicare Part D and offering $0 copays, and that was the big supplemental benefit. And times have changed in the last almost 20 years, and I think you're right. From a marketing perspective, these supplemental benefits are not the headliners like drugs and $0 premiums were. Instead, now it's going to be about the tools that plans can use with their provider partners to be able to reduce the overall cost of care and give their members a superior overall customer experience and clinical experience.
That makes sense. Catherine?
Our next question is, with telehealth and remote monitoring, what is the impact of offering reimbursement for specific CPT codes versus overall financial alignment under value-based model?
Bruce, I know that's a topic near and dear to your heart. What do you think?
Yeah, so, all right, we'll just extend this webinar for another 3 hours to answer that question. That was so good. Well, I think that here's the thing. The CPT codes are really to get the primary care physician and that clinic engaged. And I think there's no way this goes well without really leadership from the physician community. At the same time, if it's just that alone, I think that this is going to be an underused benefit, because you have to have the financial alignment, which will then bring each of the pieces necessary to make remote patient management happen. Like I said, whether it's the call center approach, it's people that can go to the home to take it into action instead of just knowing that your patient has to go to the emergency department. It's really going to be these elements that bring together multiple pieces of the continuum of care to operate in some more comprehensive and aligned manner. Once we put those together, and it's not really that hard. I'm actually here in Chicago at a conference with hospitals and device manufacturers having this discussion this morning, about doing that in several prestigious health systems in a way to go ahead and create that alignment and bring overall total cost of care down. And like I said, my pitch to them is, be very careful how you select your patients, because if you have a patient with a high expectation of high expenditures, you have a much better shot at saving money than if you go to every patient, say, with that has had a hemoglobin A1C test in the last 6 months, and you are expecting to have some savings based out of that. So I think that's where the science has to catch up with the technology.
I would agree. And I know our time is actually 20 seconds over, but one last comment. If the technology is cheap enough, you can actually offer it to way more people. And I don't think we've seen the manufacturers or the service providers who use those technologies drive the cost of the monitoring technology down far enough so that we can offer it to more people. Unfortunately, we're out of time. We won't be able to answer all the questions we have. Catherine, I know that you wanted to help us wrap up, and so I just want to thank everyone for your attention this afternoon, and look forward to further discussions of these topics ahead. Thank you.
Thank you.
Thank you, Dr. Cantor and Bruce. I want to thank you for that presentation and for sharing your expertise with us today. I also want to thank our audience for participating in today's webinar. Please watch for an email in the coming days with a link to the slides and recording of this presentation. This does conclude today's presentation. Thank you again, and enjoy the rest of your day.